Are you seeing my screen?
واضح.
واضح? Okay, I'm going to start. Septic arthritis and osteomyelitis in children is the first part of this lecture. But I will be including infections following trauma. I'll be including infections of the spine and the management, and a section on the bacteriology. Bacteria gain access to the joint via hematogenous dissemination by local spread of the disease or via inoculation from trauma or surgery. And if we're doing any surgery, there is a possibility of having an infection. Trauma could lead to infection. It can spread from other regions of the body by means of the hematogenous route. In the spine, it can spread by means of Batson's plexus. So you have to keep this in mind. Batson's plexus is a plexus of veins without valves. So if one has a increased vascular pressure, such as sneezing or passing a stool, this will revert the blood circulation and the organism can reach the spine. So don't forget about Batson's plexus in the spine, besides arterial route. The metaphysis of long bone is intra-articular, and this is a question we like to ask in the proximal radius. ما بسمع شو القصة؟ في شي problem؟ في شي problem؟ الو مين فات على الخط؟ طيب okay. The metaphysis is intra-articular in the proximal radius, proximal humerus, proximal femur, and distal fibula. So if one asks, what are the four regions where the proximal radius or humerus or femur and distal fibula can cause infection? These are the four areas. Why? Because the metaphysis is present within the capsule. So if you have an infection of the metaphysis, it can go into the joint and it can cause a septic arthritis. So keep this in mind. This slide I love. This is an AP radiograph from a 24-year-old man, 2 years after open tibia fracture. Notice the dents, the cortical bone at the medial border of the tibia, which represents sequestrum. I'm going to put the pointer on the area. This is sequestrum. This is dead bone. The new bone formation is known as involucrum. The sequestrum is more dense. Why? Because it is avascular. Calcium cannot be removed from the bony area, secondary to remodeling. As a result, it remains more dense. So you have to keep this in mind. Now, when we're speaking about osteomyelitis of long bone, we should classify it into 4 types. One is a type which is totally intramedullary. The cortices are intact. The infection is present mainly in the medulla, but the cortices are intact. Type 2 is one which is subperiosteal, and a portion of the infection is intact. Type 5 is completely eroded. And finally, type 4 is where the cortices on all sides are eroded. And this is an unstable osteoseptic or septic osteomyelitis of a long shaft of bone. It is of a permeative nature. And this is known as the Ciarni-Maeder anatomic classification of osteomyelitis. And I repeat, type 1 is intramedullary osteomyelitis. Type 2 is superficial osteomyelitis with no intramedullary involvement. Type 3 is invasive, localized osteomyelitis with intramedullary extension, but with maintained stable, and this is stable, one is intact. And finally, type 4 is invasive, diffuse osteomyelitis with involvement of the entire axial segment of bone, such that excision of the involved segment leaves a segmental defect in the limb. It is totally unstable. طلعوا بالصور فوق تقشعوا بتفسركم هالصور. But type 1, you have an intramedullary. Type 2, only one side and incomplete. Type 3 is one side and complete. And type 4 is both sides or all sides and is an unstable septic osteomyelitis of the shaft of a long bone. So, when you speak about the type in this classification, we speak about the infectious status. Type A is normal physiologic responses to infection. Type B is locally active impairment of normal physiologic responses to infection. B is a systemic active impairment of normal physiologic responses to infection. And C, as type 4 in the Ciarni classification, is a severe infection. You should look at these tables. You should memorize these tables because they come, okay? Look at them in your books, in your review books. What about biology? Classically, osteomyelitis occurs via hematogenous sequence or direct inoculation, most typically secondary to trauma. Infection is obtained from the outside world. Keep feeding of the bacteria at the metaphyseal end, arterioles, and is seen mostly commonly in the pediatric population. If you look at the metaphyses, they are end arterioles. They are curved. You have at the end of a curve eddy currents, and any minor trauma can cause a deposition of organisms in the metaphysis. We also know that the metaphysis lacks macrophages. You have to keep this in mind. And that's why the infection is usually in children localized to the metaphysis. Possible pathogens include not only bacteria, but they can be yeast. Although most cases are staph, strep, Enterococcus and Pseudomonas. I've seen cases of tuberculosis, Mycobacterium tuberculosis. I've seen fungus infections and yeast infections occurring in the metaphysis. Keep this in mind. But the most common organism is Staph aureus, followed by strep and Enterococcus. Acute osteomyelitis is characterized by rapid presentation and a rapidly evident purulent infection, which represents the first episode of bone infection. There hasn't been any pre-infection. One question we like to ask is, could it be an acute osteomyelitis if a patient has had a previous infection? The answer is no. You should answer on a previous infection. But osteomyelitis can become chronic over time. What about chronic osteomyelitis? It can be present for decades. For decades. You know that there are episodes of quietness and then activity. When you treat the osteomyelitis of the femur, you think you've treated it, but they can be dormant, necrotic bone, which serves as a zone where the organism can hide or lodge in, where antibiotics cannot reach them due to the poor circulation, due to the bad circulation. A known antecedent event, or as arranged in the host, could provoke recurrence of the infection. What about the biofilm? We hear about it a lot, the biofilm, in reconstructive surgery, whether total knees or total hips. The initial inoculum involves bacteria in the planktonic phase. It is in a liberal phase. They are mobile. They float freely and exhibit a high metabolic rate. Now, once the bacteria inhabit in a biofilm, in a cryoprecipitate of mucopolysaccharides, all these with proteins, they form a coverage or a shield, as in the fighting process. They put sandbags as a shield to prevent prevent antibiotics from arriving to the organism and trying to destroy them. Okay, so keep this in mind. A biofilm is a protective shield. The biofilm bacteria complex is the entity comprising the bacteria in an extracellular matrix with a glycocalyx. This matrix is avascular, making it difficult for antibiotics to penetrate. So the shield protects it from the antibiotics. And depending on the microbe, the biofilm layer usually forms between 8 and 14 days following the planktonic colonization of the bone. That's why in the different phases in which the management is carried out on a total hip or a total knee, each stage is managed differently. Why do we keep the prosthesis in the first 3 weeks following a total hip? Because there wasn't enough time for the biofilm to form. So we like to deal with it early. Biofilm represents the first line of response of bacterial colonization, in which the initial colony invasion falls on the soil to create a bacterial friendly environment for the rest of the colony to inhabit. It consists of dead bacterial sludge milieu. A mature biofilm complex represents the greatest barrier to treatment and effective eradication of musculoskeletal infections, especially if the infection involves bone or is implant related. This is due to the fact that the microbes enter into a sessile phase with markedly reduced metabolic rate, as well as the fact that the biofilm itself impairs efficacy because it represents a barrier to diffusion. What about the evaluation and clinical presentation? A draining sinus is the classic presentation of osteomyelitis. Often the sinus tracts are multifocal in nature. Over here in the slide, you see an elbow, which is involved by tuberculosis, Mycobacterium tuberculosis. You see that there's two draining sinuses in the elbow region. In acute osteomyelitis, secondary to trauma, the clinical manifestation is exposed bone or a non-healing soupy soft tissue envelope over the bone. Indolent infections might present with only chronic swelling and induration, occasionally accompanied by recurrent bouts of cellulitis. What about imaging? Radiographic evaluation of the affected limb segment is performed. Osteomyelitis can present radiographically as areas of osteolysis, acutely, then chronically as areas of dense sclerotic bone because of the avascular necrotic nature of osteomyelitic bone. What we're seeing in a plain film, that is after 14 days, we begin to see that there is dead bone, and this is called sequestrum. And we begin to see that there's newly formed bone, and this is called involucrum. So this, keep in mind, by looking at the plain radiograph of the extremity. When a necrotic segment of free devascularized infected bone is left in a limb, over time, it becomes radiodense on radiographs. And this is called the sequestrum. I repeatedly say sequestrum because I've asked this question on previous exams to name the dead bone, to name the bone which is increasingly intense or dense. And nobody gave me the name of sequestrum. You have to remember this. Occasionally, it will be engulfed and surrounded or walled off by healthy bone. It is then called an involucrum. What about laboratory studies? One moment, please. I'll take a break just for a second. Hello, now. Hello. Like it, hi, Nina. Lucky, can you call me back in after 7 o'clock because I'm giving a lecture online abroad, please. Okay, thanks. I'm sorry I had to leave. I have to answer the phone. The laboratory studies, hematologic profiles, are routine in the evaluation of osteomyelitis. Blood tests that should be ordered include CBC with differential, ESR, and C-reactive protein. These studies we routinely ask for. What is the white blood count? How much is the ESR? And what about the CRP? Which has the CRP declined? Is the ESR still elevated? All these are questions we ask with regard to the lab results. In acute osteomyelitis, elevated white blood cell count, platelet count, ESR, and C-reactive protein level may be present. Neutrophilia of the differential is often present, meaning the neutrophil count is elevated. In chronic osteomyelitis, now pay attention, we were speaking about acute osteomyelitis, but in chronic osteomyelitis, the white blood count, the platelet counts, these are usually normal. And often the ESR is normal, and even the CRP can be normal. So you have to differentiate between acute osteomyelitis and chronic osteomyelitis. Surgery or trauma also can elevate the platelet count, the sedimentation rate, the C-reactive protein level. The platelet count generally returns to normal once the hemoglobin level has stabilized to a more normal range. The C-reactive protein value usually normalizes within 2 to 4 weeks, while the ESR returns to normal within 4 to 8 weeks. What about the tissue culture? The diagnosis of osteomyelitis depends on obtaining appropriate culture specimens. Appropriate culture specimens. You have to try and obtain 3 cultures. Send them. If you find that in 2 they're the same, then you can confirm the presence of an infection. The benchmark for proper diagnosis is obtaining good tissue samples for culture. If an abscess cavity exists, this can sometimes be performed adequately with needle aspiration. Appropriate bacterial and fungal plating of the specimen is important. You have to choose the proper plates for fungus, for aerobic media, for anaerobic media. In chronic osteomyelitis, the culture specimens sometimes fail to grow. But this does not mean that infection is absent, but rather that the offending organisms cannot be grown successfully. Often patients with chronic osteomyelitis have received multiple courses of antibiotic therapy, making it hard to grow the organisms in a laboratory setting. Right, some antibiotics, right and left, and then they make it very hard for the infectious disease man to manage the case. Much new interest has focused on using polymerase chain reaction, PCRs, analysis of specimens. If you're asked what's a PCR, you should say it's an analysis of the DNA of that particular organism. And this will diagnose the infection at an earlier time. What about the classification? The most widely accepted clinical staging system for osteomyelitis is the Thiani-Maeder system. I will show it to you, and that I showed you in the table before. And this system considers the anatomy of the bone involvement, which I spoke to you about, and then subclassifies the disease according to the physiologic status of the host. Thus, in both tables that I've shown you at the beginning of my lecture, they discussed in detail the Thiani-Maeder system. And believe me, you should memorize this. There's not one board exam unless you have in the oral 1 or 2 cases of septic bone, and you have to go through discussing it. Please remember the tables. This staging method helps define the lesion and the ability of the host to deal with the process. The prognosis has been well correlated with the physiologic host subclassification. What about the general treatment principles? Once the osteomyelitis has been staged and the condition of the host has been defined, the condition of the host is very important. Is he immunosuppressed, or whatever condition he has? What systemicness? And this is optimized. A treatment plan individualized to the patient's condition and the goals can be determined. Ideally, the goal of treatment is complete eradication of osteomyelitis with a preserved soft tissue envelope, a healed bone segment, and preserved limb length and function. When I was young like you, I was taught that once in osteomyelitis, always in osteomyelitis. And many compared osteomyelitis to aggressive bone disease, like tumors. So you can imagine that you can always have reactivation of an osteomyelitis following treatment. Because of the extreme variation in the way osteomyelitis presents and manifests itself in different people, there is a paucity of good evidence-based data to aid in making treatment guidelines. Surgical treatment. Surgical debridement is the cornerstone of osteomyelitis treatment. Adequate debridement is achieved when all infected and devitalized bone and tissue have been excised. Debridement of any dense fibrotic scar is also necessary because it is often white, avascular, and represents a poor soft tissue bed for healing. Atrophic skin that has become adherent to the bone. The medial border of the tibia is a zone which is very common for this to occur, also requires debridement because of its impaired blood supply and compliance. It may not be possible to preserve enough bone or tissue for a functional limb. In these cases, amputation may be required or preferred. But our aim is to try and save an extremity. We should not aim at amputation from the very beginning. We should analyze each patient carefully and then decide on the treatment. Skeletal stabilization of the affected limb is necessary when mechanical instability results from debridement. And this particularly happens when all cortices are involved. This includes all type 4 lesions and some type 3 lesions where a large amount of bone has been removed. If a segmental defect is created with the debridement, then proper planning in skeletal stabilization must occur from the start. From the start, you should know whether you're going to end up with an unstable extremity. So you have to be prepared of what you want to do to stabilize this. It should be with a clear and comprehensive plan to establish a proper, stable extremity. If a segmental defect is created with the debridement, then proper planning in skeletal stabilization must occur from the start with a clear and comprehensive plan established to gain bony stability of the limb. Stabilization is accomplished most often with external fixation. It also can be accomplished with antibiotic impregnated cement coated medullary nails or plates. And this, believe me, has been very effective. I have used this on several cases. You can make it handmade. You get a rod, you get your cement, you mix it with the proper indicated antibiotics, and then you surround your rod with the cement, and then you insert the rod in. Or you can do the same process on plates. For small defects, less than 2 centimeters, acute shortening remains a reasonable option for treatment, especially in the upper extremity. Delayed bone grafting or osteomyocutaneous free tissue transfer is also possible after infection eradication. For some large osseous defects, quite large, the best option remains bone transport using distraction, osteogenesis. Dead space management is important. Debridement creates a dead space. This space requires appropriate management while the infection is being eradicated. We don't like dead space. The dead space can be filled by means of local muscle mobilization, a rotational muscle flap, as the gastrocnemius, a free muscle flap, a free faciocutaneous flap, or rotational perforator-based flap. Now, I will tell you, quite a number of these cases are being treated with an experienced plastic surgeon, experienced in developing flaps, free and not free flaps to fill out the dead space. Working together as a group will give you the best results. The vac sponge is a useful short-term adjunct to assist in dead space management until definitive soft tissue coverage is achieved. If placed directly over cortical bone for an extended period, it can result in desiccation and death of the cortical bone beneath. We should not apply it directly on cortical bone. Antibiotic impregnated polymethylmethylcrylate beads are a time-honored method for managing dead space. They also provide an effective means of local high-dose antibiotic delivery. But it's important, when you apply these, don't put the drain, you lose quite a significant amount of the antibiotic effect if you do put the drain. Most surgeons make their own beads. May I answer the phone just 1 second? فادي أنا بلشت اللكشة حبيبي احكيني بعدين. Most surgeons make their own beads by mixing PMMA with tobramycin and vancomycin powder. Other antibiotics used include gentamicin, erythromycin, tetracycline, and colistin. In general, heat-stable antibiotics can be used. I repeat, heat-stable antibiotics can be used. Because don't forget that the cement, as it sets, it provides heat. It can destroy whatever antibiotic that is not stable under the influence of heat. Resorbable materials, including calcium sulfate, calcium phosphate, hydroxyapatite ceramic beads with antibiotic impregnation have recently been introduced, but their clinical efficacy has not yet been well established. Antibiotic impregnated PMMA beads can be used effectively with or without a closed soft tissue envelope. With an open soft tissue envelope, the beads can be placed and then the limb and wound wrapped with an adhesive coated plastic film laminate. These are available on the market. This provides a biologic barrier with high dose local antibiotic delivery and usually does well for 4 to 6 days before requiring changing because of leakage. With a closed soft tissue envelope, the beads can be left in for an extended period to further ensure that the infection has been controlled. If it is not a closed envelope, you lose the effect of the antibiotic. So you need the cellophane, tight closure, no drains. Soft tissue coverage, a close working relationship with a microsurgeon or plastic surgeon experienced in soft tissue mobilization and free tissue transfer is imperative in managing osteomyelitis with soft tissue void or an impaired soft tissue envelope. Rotational flaps are a good adjuvant for certain soft tissue defects or when a microsurgeon is not available. Flap coverage combined with bone transport to fill large bone and soft tissue defects is safe and effective and has good long-term results. What about the antibiotic coverage? Parenteral antibiotics are administered after debridement has been performed. Treatment protocols frequently involve a 6-week intravenous antibiotic regimen. With the sharp increase in organisms developing antibiotic resistance, such as methicillin-resistant Staph aureus or vancomycin-resistant Enterococcus, inappropriate antibiotic regimen may need to include daptomycin. In certain instances, C-host, which I was present in the table that was given at the beginning of the lecture, long-term antibiotic suppression can be the treatment of choice. Distraction osteogenesis due to the frequency of segmental defects in osteomyelitis treatment, bone transport using distraction osteogenesis is often required. Distraction osteogenesis is the process of creating new bone or regenerate by gradual distraction at the corticotomy site. A corticotomy is a low-energy periosteum-sparing osteotomy. Distraction osteogenesis requires a latency phase followed by distraction at the proper rate and rhythm. A typical latency period is 5 to 10 days. Yani you do your osteotomy, then in 5 to 10 days you begin the distraction, depending on the bone and healing potential at the corticotomy. The standard rate and rhythm is 1 millimeter distraction per day, divided into 0.25 millimeter increments 4 times daily. Yani 1 millimeter, you divide it into 4 parts and gradually you increase the length. Slower distraction or smaller increments may be necessary in other long bones and not the femur. The consolidation phase typically lasts twice as long as the distraction phase. Radical debridement of all non-viable bone, soft tissue, and inert material is the critical step in the treatment of osteomyelitis. Proper dead space management and soft tissue coverage are similarly important. The host and the bone involvement should be staged properly at the beginning of treatment so that an appropriate treatment plan can be established. Biofilm currently presents the major limiting factor in eradicating microbes with antibiotics in the care of infection, especially implant-related and bone infections. Local and parenteral antibiotic treatment is the standard of care. Direct spread from a metaphyseal osteomyelitis is a higher risk at the elbow, shoulder, hip, and ankle. In these joints, bacteria may directly invade the joint from the metaphysis in children up to 12 to 18 months. We know that there is a direct connection between the metaphysis and the epiphysis in children up to 12 to 18 months, after which it becomes blocked. But there remains another route. These metaphyses are present within the capsule, and therefore they can have an infection involving the joint and the metaphysis of bone, combined osteomyelitis and septic arthritis. Young age, prior trauma to the joint, systemic diseases affecting the joint, rheumatoid arthritis, hemophilia, and immunocompromised states all increase susceptibility to septic arthritis. Staph aureus is the most common pathogen of septic arthritis in all of these age groups. Haemophilus influenza has been a common cause of septic arthritis in children less than 2 years old, but the H or Haemophilus influenza B vaccine has decreased the incidence of Haemophilus influenza related septic arthritis. Organisms are found in septic arthritis associated with trauma, and these include the gram-negative bacilli, anaerobes, Staph aureus are the most common pathogens found in septic arthritis associated with trauma. And those found with hemophilia are Staph aureus, strep, gram-negative bacilli are the most common pathogens found in septic arthritis associated with hemophilia. In immunocompromised patients, the most common organisms include Staph aureus, mycobacteria, and fungi. These are the most common pathogens found in septic arthritis in immunocompromised patients. So you have to keep this in mind. Children often present with a history of limping. They limp. They might not complain of pain, but they refuse to walk or bear weight at times. They have fuzziness, they have or recent trauma to the joint. On exam, the joint may be swollen, warm, and erythematous. A patient will hold a septic hip, inflection and external rotation, and a septic knee, inflection, because these positions maximize volume within the capsule and tend to be more comfortable. Pain with short arc passive range of motion, micro motion pain, is characteristic of septic arthritis. Absence of micro motion pain decreases the likelihood of septic arthritis, although the entire clinical picture must be used in making a diagnosis. A high index of clinical suspicion is required, as no algorithm has been universally accepted thus far. Now, what are the kosher criteria? This is very important. Why? Because this is asked often in examinations. They are also useful in judging septic hip arthritis in children. These criteria include inability to weight bear on the affected side. That's number one. An ESR of 40 millimeters or more. This is 2. Fever, 3. And a white blood cell count more than 12,000 cells per cubic millimeter. When 1/4 of these is present, يعني ربع اسمه موجودين. يعني either fever, either an elevated sedimentation rate, or white blood count, then the chances for a septic arthritis to exist would be only 3%. If all 4 are present, the chances of a septic arthritis is 99%. More recent studies suggest that the C-reactive protein is a useful adjunct to this prediction model. Neonates have a less robust inflammatory response. And the characteristic signs of infection include fever, swelling, erythema, and pain with motion may be absent. So you have to pay attention. The only sign you can see is that the child limits the motion of that extremity, or he holds his extremity either in external rotation, or if the knee is involved, in flexion. It is crucial to have a high suspicion with reports of irritable behavior, failure to thrive, asymmetric extremity movement, and coincident infections. X-rays of symptomatic joint should be obtained in a patient being evaluated for septic arthritis. They can help narrow the differential diagnosis, as it may reveal fractures or bone lesions that are sources of joint pain. Radiographs can also increase your suspicion for septic arthritis if a joint effusion, localized soft tissue swelling, or evidence of osteomyelitis is present. However, a normal X-ray does not, I repeat, does not rule out septic arthritis or an occult fracture. Ultrasonography is particularly useful in septic arthritis of the hip, since an effusion is not appreciable on clinical exam as with the knee or ankle. It can also be used to guide aspiration of a hip effusion to send for laboratory studies. MRI will demonstrate a joint effusion and often synovial inflammation or hypertrophy, but should not delay intervention when the characteristic signs and symptoms are present. Radionuclide bone scans will highlight regions of inflammation, but are not specific, therefore are rarely used in evaluating septic arthritis. The definitive diagnosis of septic arthritis is based on culture, a pathogen from the synovial fluid of the affected joint, because the culture results can take days to identify an organism. The cell count and the gram stain are used as preliminary indicators. Nowadays, really, we don't depend so much on the gram stain, but it helps us. A white blood count greater than 50,000 cells per cubic millimeter and a neutrophilia of 90% is suggestive of septic arthritis, although occasionally other pathologies can give it. Juvenile idiopathic arthritis, Lyme's disease, have similar values. Immunocompromised patients may have a lower white blood cell count in the setting of septic arthritis. Culture negative septic arthritis is not uncommon in children, so treatment should not be aborted early if the cultures fail to grow in the organism. You have to know of how, what are the routes used for joint aspiration. For an ankle aspiration, insert the needle approximately 1 centimeter anterior to the lateral malleolus at the level of the joint line, just lateral to the extensor digitorum longus. Or you can do it medially with relation to the medial malleolus. For knee aspiration, there are two ways. One is to go lateral. For a knee aspiration, insert the needle lateral at the level of the superior pole of the patella. Alternately, with knee flexed, you can insert the needle medial or lateral to the patella tendon at the level of the joint line. A hip aspiration should be performed under sound or fluoroscopic guidance. The needle can be inserted anteriorly 1 inch lateral and distal to the ligament, the inguinal ligament, medially inferior to the adductor longus, or laterally inferior and anterior to the greater trochanter. These show you the routes of aspiration: anteriorly, laterally, and you have to pay attention to it. You have to always palpate the vessels the femoral artery beneath the inguinal ligament and put your needle in relation to this to avoid injuring the vessel. Damage to the articular cartilage begins within 18 to 24 hours from the start of the infection, and irreversible changes likely occur after several days. By 4 weeks, the articular surface may be destroyed. A delay in treatment can result in irreversible joint damage. A vascular necrosis of the hip may also occur due to tamponade of the blood vessels from a tense effusion, mandating early diagnosis and prompt drainage of septic arthritis. While repeated aspiration is an option in smaller joints, larger joints are typically managed with surgical drainage and irrigation and antibiotic therapy, typically 3 to 6 weeks. Septic arthritis of the hip is treated as a surgical emergency. Intravenous antibiotics are administered initially and are often switched to an oral regimen within a few days based on the patient's clinical response. Empiric antibiotics should ideally be started after a sample of synovial fluid is obtained. The choice of antibiotic should then be tailored to the culture and sensitivity results when available. Patients are monitored for response to both interventions. Failure to improve should prompt adjustment of antibiotics, repeat surgical drainage, or a search for an alternate diagnosis. Transient synovitis. I would like to take 5 minutes break now. It's been over an hour. Okay? Dr. Khalid.
دكتور جون
كل
شيء واضح، تسلم، شكرا.
اوكي، عم بعطيهم كل شيء يلي معقول يجيهم بالفحص.
اكيد كل النقاط مذكوره يعني، وهم بيستفيدوا ان شاء الله كلهم.
They have to learn how to discuss. They have to learn what are the complications, what are the indications, how to do the procedure, how to get rid of a dead space. What antibiotics could they include in the cement? ما يحطوا لي حيلا antibiotic اللي with heat they are deactivated. These are points that they should know.
دكتور جون.
Yes.
خلاص خذ راحتك 5 دقائق ونرجع.
5 دقائق. اوكي.
يلا اذا بعد.
Transient synovitis. If you look at the slide, it summarizes the condition. Transient synovitis is the most common cause of hip pain and of a limp in a preschool child and early grade school age children. Transient synovitis is also known as toxic synovitis. Irritable hip and observation hip. If you look at an ultrasound of a hip in a child with transient synovitis, you can see that in between the two asterisks, the white crosses, you see that there's a fluid collection. This usually occurs following an upper respiratory tract infection with, let's say, a fever of 37.5, and the patient really is not really very sick. But if you give them a simple anti-inflammatory drug, they will respond quickly. We think it could be due to an allergic reaction, antigen-antibody reaction. We're not sure, but. Oh, transient synovitis. That's it. Okay. Transient synovitis is among the most common causes of limp in the young child. An individual has approximately a 3% risk of having at least one episode of transient synovitis in his or her childhood period. Boys are affected twice as often as girls. The child will walk with an antalgic gait or may refuse to walk altogether. The hip is most comfortable in a position of flexion and external rotation. Again, I repeat, this position is taken where the maximum amount of fluid can be present within the hip. Passive range of motion of the hip is mildly restricted, usually due to guarding, and there may be some discomfort at the end ranges of rotation, especially internal rotation. The physical findings may be similar to septic arthritis, although patients with septic arthritis usually have more pronounced discomfort, which is present at rest, and pain is elicited throughout the range of motion. In general, imaging studies are of limited value in the diagnosis of transient synovitis of the hip. Radiographs occasionally show an enlarged joint space from a hip effusion. Ultrasound is more sensitive than the radiography for detecting an effusion, but still is not specific for the diagnosis. MRI may be useful to detect joint effusion or subperiosteal abscesses. The COSHA criteria are for physical examination or laboratory findings used to differentiate transient synovitis from septic arthritis. You have to pay attention to this. And you use the 4 criteria that I mentioned to you about the ESR, about the fever, about the, what do you call it? Yeah. All the 4 criteria. I will go back to them and tell you them. You have to compare the 4 criteria: refusal to walk, fever, an elevated white blood count, neutrophilia. All these add to the differential diagnosis between a septic hip and a transient synovitis. Although these criteria are not validated by other studies, they are the most frequently utilized for clinical decision making. The 4 criteria are the history, fever, inability to bear weight. We spoke about ESR 40 and the white blood cell count, which is more than 12,000. And the presence of all 4 criteria predicted a 99% chance that the diagnosis was septic arthritis and not transient synovitis. Transient synovitis is a lower and less toxic and less reactive involvement of the hip. In septic, it is more severe. The positive criteria correlated with 93% chance for 2 positive criteria with 40% chance and only 1 with 3% chance of the patient having septic arthritis. Recent evidence suggests that a C-reactive protein level greater than 2 milligrams per deciliter for C-reactive level greater than 2 milligrams per deciliter is a strong independent factor in differentiating septic arthritis from transient synovitis. Hip joint aspiration with cell count, gram stain, and culture should be performed in cases for which septic arthritis is suspected. Conservative management is the rule for treatment of transient synovitis of the hip. Anti-inflammatories tend to have a remarkable and quick effect on the plane and may shorten the duration of the condition. Weight bearing of the affected hip may be restricted until the symptoms resolve. Most patients experience significant relief by 5 to 7 days, although complete resolution may take up to 4 to 6 weeks. Prolonged symptoms should prompt re-evaluation to rule out other diagnoses. Osteomyelitis. Acute hematogenous osteomyelitis. This is going to be a rapid discussion, and it involves the treatment mostly in an adult. It usually affects the metaphysis of bone. The metaphysis has a sluggish blood supply, as I mentioned at the beginning. Bacteria from distant focus, skin, teeth, nose, will be carried by the blood, and hence the name hematogenous, and then settle in the metaphysis with its slow circulation, eddy currents, and loop formation. All these, together with a minor trauma, can help localize the organism in the metaphysis, plus the absence of sufficient amount of macrophages all add to the infection within the metaphysis. They have fever, limp, refusal to bear weight, erythema, warmth, swelling, and point tenderness over the metaphysis are all common signs of osteomyelitis. It is important to look for open wounds in children who are non-ambulatory or have chronic diseases that limit their mobility or sensation. Recent puncture wounds can also suggest osteomyelitis that developed after a trauma. Plain radiographs, we spoke about them to evaluate osteomyelitis. The changes are apparent at 10 to 14 days, as I have mentioned. And early stage osteomyelitis may have normal X-rays, in which case further imaging with MRI may be warranted. MRI features of osteomyelitis include bone edema, intraosseous or subperiosteal abscess, soft tissue inflammation, effusion, and myositis. Bone scans are used less frequently in the workup of osteomyelitis because severe infections can show low activity due to compromised osseous microcirculation and can be more difficult to interpret in small children. This slide I like because it shows the route in which pus can go to the knee on the left, and one in green, you see that it can go to the subperiosteal region, and in 3, the periosteum can be perforated, and you'll end up having a sinus tract. A complete blood cell count with differential ESR, CRP, and blood cultures should be obtained. A normal white blood cell count, as I said, does not rule out an osteomyelitis. Aspiration of the metaphyseal region should be considered when there is a point tenderness on examination, as a subperiosteal abscess may be identified and fluid sent for culture. ESR takes longer to return to normal levels following infection, typically about 3 weeks. C-reactive protein is an acute phase reactant that rises and descends more quickly than ESR in the setting of infection. C-reactive protein level may normalize within a week of initiation of effective treatment. As such, C-reactive protein is better marker to monitor the response to treatment. These are terms related to chronic osteomyelitis. A sequestrum is a fragment of necrotic bone that has been walled off by infection. Sequestrum may be partially or completely resolved by the host response, especially in children, and it must be removed to clear the osteomyelitis. An involucrum represents the host response and involves periosteal new bone formation, which serves to wall off the sequestrate and restore mechanical stability to the involved segment of bone. Sequestrectomy should be delayed until sufficient involucrum has been formed. Otherwise, segmental bone loss may occur. As with septic arthritis, Staph aureus is the most common organism. Neonatal osteomyelitis may be caused by E. coli, strep, enterobacteriae, and Candida albicans. All cases of osteomyelitis treated with intravenous antibiotics based on culture and sensitivity results. If a causative organism is not isolated, antibiotics are selected empirically After response to intravenous antibiotics has been demonstrated, conversion to an oral antibiotic regimen can be considered, and in fact, recent evidence supports earlier switch to oral antibiotics based on organism and clinical response. Antibiotic treatment typically lasts for 6 weeks. If diagnosed early, uncomplicated cases of osteomyelitis do not require surgical intervention. However, the presence of a drainable intraosseous or subperiosteal abscess or bony destruction on X-ray is an appropriate indication for surgery. Patients who do not respond to intravenous antibiotics after 48 hours are also candidates for surgical intervention. All cases of chronic osteomyelitis warrant surgical debridement and removal of any devitalized tissues as the primary treatment strategy, and antibiotics serve as an adjunct in these cases. The physis can be damaged in metaphyseal osteomyelitis, leading to physeal arrest with deformities. You have to keep this in mind. Septic arthritis occurs approximately twice as frequently as osteomyelitis in children. They also tend to affect different age groups, with septic arthritis more common in patients less than 5 years old and osteomyelitis more common in patients 5 to 10 years. Septic arthritis and osteomyelitis affect the same joint simultaneously in about 20 to 30% of cases. In infants, this dual infection is thought to occur because the epiphyseal and metaphyseal circulation communicate. After approximately 12 to 18 months of age, the physis serves as a barrier to spread of infection. Joints in which the metastasis is intra-articular, proximal femur, casa, are more prone to direct spread from a metaphyseal focus or osteomyelitis. So, you have to know certain definitions in pediatric hematogenous osteomyelitis. The word osteomyelitis stands to describe a term, infection involving bone. Osteon stands for bone. Myelo stands for bone marrow, and itis stands for infection. You have to know these. An infection should be strongly suspected in a child whenever he presents with pain, swelling, tenderness in the limbs and spine and pelvis. You have to know these rules in pediatric hematogenous osteomyelitis: rubor, redness; tumor, swelling; Kähler, heat; Dolor, pain. These are the 4 descriptive of pediatric hematogenous osteomyelitis. One should always think of a differential diagnosis, which should include rheumatic fever, septic arthritis, cellulitis, Ewing sarcoma, or leukemia, thrombophlebitis, sickle cell crisis, Gaucher's disease, and toxic synovitis. The risk factors, we spoke about them: trauma, regional ischemia, bacteremia, illness, malnutrition, immune system deficiency. Infection begins in the metaphyseal venous sinusoid, sluggish blood flow, poor developed reticuloendothelial system. All these I have mentioned. The exudate exits porous metaphyseal cortex and forms a subperiosteal abscess in the type C, as I showed you. You have to know about the involucrum and the sequestrum. And this shows it to you repeatedly. You can have multiple sites of infection you have to think of, okay? You should not forget about the retropharyngeal abscess or grisly abscess or the felon or the paronychia. We spoke about this in other lectures. You should not forget about the subperiosteal abscess collection. You can have a hematoma in the heel, and you can end up having an insufficiency and infection. These are the routes by which you can have it. This is showing the hip, where you can have an infection in the hip going into the through the inferior neck of the femur into the capsule. You should know the difference between an acute hematogenous osteomyelitis. If you look at the cells on the right-hand side, you see the inflammatory process, neutropenia, while on the left-hand side, you see bone and callus and trabecular formation, which is the normal bone. You have to know about how beware of drainage, okay? You have to also be aware of a septic knee when it's flexed. You have to know whether the child has pain or sudden pain on micromotion. This is a patient who has an osteomyelitis involving the metaphysis, which has gone to the subperiosteal region through Volkmann's scan, formed a subperiosteal abscess on the medial aspect of the tibia. Technetium bone scans or gallium or indium all show an increased uptake. If you want to tell whether there is multiple involvement, a PET scan will help. So don't forget this. On MRI, you have an increased signal intensity on T2. What are the complications of chronic osteomyelitis? You have to think of non-union, malunion, pathologic fractures, epiphyseal growth disturbances, and squamous cell carcinoma, which develop along the sinus tracts. Don't forget this. And chronic cases end up having amyloidosis. So keep these as complications. We have gone through these, but you have to know that you can have even an embolus of the uterine vessel with infection and involvement of the whole bone. And if you see that over here, I'll show you. Over here, you have the involucrum, but inside, this is dead bone. You can see that in the hip, they could end up with severe dislocation, disease, and you can have a later involvement of other joints. This patient was a Puerto Rican. He had a poor defense mechanism, and you can see the shortening that has occurred. This is another patient with a septic that was not treated early, and the patient ended up with a dislocation. Lyme's disease is exposure to a tick bite. They have a typical target rash, erythema chronicum, migrans. They have intermittent arthritis, and this is caused by a spirochete, which is called Borrelia burgdorferi, and the treatment with penicillin and tetracycline or erythromycin are effective. So don't forget, this is Lyme. They appear like this, reddish areas around the skin. And there are certain areas in the States where it is common to have. So, I want want you to, you see, these are taken from our cases at the DuPont Institute in Wilmington, Delaware. For instance, I'm going to show you a few cases. Wait, let me show you a few cases. Okay. Let's take this as a general case. There is a history of recent or concurrent infection in 1/3 to half of the cases. These patients would have unexplained bone pain and fever. Osteomyelitis, until proven otherwise, is the presumptive diagnosis. A white blood cell count is not invariably elevated. Taken from Scott, 41% had white blood cell counts less than 10,500. The ESR is elevated in the majority of cases. C-reactive protein increase in 98% of the cases. And blood cultures are usually positive in 40 to 50% of cases. These are cases taken, and X-ray, plain X-ray, there was early deep soft tissue swelling in the majority. Bone changes usually are not present until 1 week following the infection. We spoke about this. Bone scans were used to rule out infections in the spine and pelvis. They have a history of non-specific trauma. They have a false negative rate in 4 to 20%. MRI sensitivity equals bone scan, specificity greater than bone scan. Aspiration, all these to confirm the presence of infection. And when you're considering the differential diagnosis of an infection, you should think of an osteoblastoma, an eosinophilic granuloma, Ewing sarcoma, osteosarcoma, Caffey's disease, and scurvy, and the battered child. Let's keep this in mind. We spoke about the treatment. I will not go through it. All these are to show you that what are the effects. Now, I would like to mention that there are people who have a good resistance. They can localize the infection into an abscess and gives you a Brody's abscess. This occurs when the organism is either not very virulent, like strep viridans, and they appear like a zone of sclerosis, and the differential diagnosis can be an osteoblastoma or osteoblastoma. I don't want to go into these cases because I lost my voice. So I will be skipping this area, and all these are repetitions. And for this reason, I most probably will be moving to the spine. Gallium scans and indium scans are great, but they're not specific, really, not specific. Indium scans take 24 hours to show their appearance. And I would like to tell you that even if you do under ultrasound aspiration to obtain pus, you can still do a scan of it. Okay, so we're going through these because all these have been discussed I just would like to show you a case. Day of admission to a hospital, this 9-month-old male child had a history of normal pregnancy, delivery, and growth. The mother noted a fever of unknown origin for the previous 2 days with vague abdominal pain, diarrhea. Initial workup revealed temperature 104 degrees Fahrenheit, white blood cell count 16,800, with a left shift, chest x-ray, abdominal, pelvis, hip x-rays, all were negative. A bone scan was even negative, and the spinal tap was negative. The infant was admitted with the diagnosis of viral infection and mycoplasma pneumonia, started on erythromycin. Hospital day 2, the right hip was noted to be flexed and orthopedic services consulted. The right hip was aspirated. Gram stain showed gram-positive organisms, started on naphthalene, 150 milligrams Q4 hours. The child then had daily hip aspirations for decompression. The final culture grew Staph aureus resistant to penicillin. Hospital day 6, the right hip x-ray showed a defect in the proximal medial metaphysis, possible osteomyelitis. The child was then taken to the operating room for incision and drainage of the right hip via anterolateral approach with suction irrigation system, and a seropurulent fluid was drained. Post-operative 7 drains were removed. He respiked to 101.6. Right hip x-ray suggested demineralization of the proximal metaphysis. The hip was re-aspirated and pus was obtained. Cultures were negative. Post-operative day 12, respite at 103.6, gentamicin 1 milligram IV added to naphthalene, daily aspirations of 10 cc pertinent fluid, all cultures were negative. Post-operative day 7 drains were removed. Post-operative day 9, afibrillar for 48 hours. Cell 15100, ESR72, right hip x-rays, changes in the proximal metaphysis, including lucency and demineralization, and the hip was subluxed, treated with oxacillin and the Pavlik. Hospital day 12, the white blood cell was 12,600, discharged home in a Pavlik illness. 2 months office follow-up, right hip x-ray, progressive destruction of the capital femoral epiphysis, cystic changes in the metaphysis with avascular necrosis. Age 6, valgus osteotomy for subluxation and 2 centimeters leg length discrepancy. Age 15, valgus osteotomy for hip. Age 20, hip arthroscopy, hip fusion recommended. Post-operative day 18, hip x-ray sublux, possible metaphyseal lucency with osteomyelitis. This is a confusing presentation, and this is finally how the patient ended. Ya Jamia, these patients can be really questionable. These patients can be very difficult to treat. You have to think of this. You have to really try from the very start to get the proper diagnosis and do the proper management on these patients. I showed you this, keep in mind. I'm just mentioning about salmonella osteomyelitis, that it's not only the organism that is present. First of all, usually it's in the diaphysis. It usually occurs following a sickle cell crisis in the area due to the lowered resistance where the organism can grow with minimal aggression from the part of the host. In the recent study, it has been shown that the most frequent organism is Staph aureus and not Salmonella. So if you're asked the question, what is the most frequent organism in Salmonella osteomyelitis, it is Staph and not Salmonella. You have to know that the osteomyelitis is different than other regions. Why? Because it involves the diaphysis. It occurs following a sickle cell crisis. Now, this shows you osteomyelitis in sickle cell anemia involving the metatarsal bones. You see, it involves many metatarsal bones. Tibial osteomyelitis, no antibiotic treatment. This is the tibia showing the involucrum. Let me show it to you. This is the involucrum. This is the sequestrum. Okay, and it shows you the sequence of treatment of these patients and what would the long-term result be. This is again a Puerto Rican child who came presenting with a limp, no pain, but the family were worried, why is he limping? These are the x-rays. Then you see that if you go back to the previous one, you see that the x-rays were not involving the lower metaphyseal region. Later on, they began to realize that there's involvement, and then you see that there's a septic arthritis and destruction of the hip joint. This was way before where we had little experience in the management of these cases. This is another patient who had pain in the proximal humerus, then gradually fever and all the works, and you can see the involucrum, and in between you have the sequestrum. Let me tell you, in children, the sequestrum could be resolved completely. You have to think of it. Could be resolved completely. This is the final result of the previous case. Again, Puerto Rico. It occurs in low or poor socioeconomic status, the high incidence of infection. This is another patient where the patient had a pin and it formed a ring sequestrum, which is a localized form of infection that could occur following the insertion of pins. But let me tell you, in eosinophilic granuloma, you can have lesions presenting as such. So when you see this lesion, you should say it's either ring sequestrum secondary to osteomyelitis, secondary to pin insertion, or it can occur in eosinophilic granuloma. Okay? Then we come to areas of the spine where you have collections in the spine, which I will be going into very soon. Don't forget that in congenital syphilis, they can have osteomyelitis, and the organism is Treponema pallidum, and they end up having destruction of the physis, and they present like this. This occurs to children who are born to mothers who have syphilis. Treponema pallidum. You have to know these. This is very important that you know about how to drain. You have to know that there's a horseshoe abscess over here. You have to know how to drain. You have to, this abscess. You have to know that the skin on the posterior aspect of the hand is soft, and any abscess would produce enlargement. These are the methods that we drain the abscesses, and what would the late results be? Okay, Chronic osteomyelitis, I'm going to go, we have discussed a good part of it. We have discussed many parts of it. So I'm going to cancel this because I want to go to the spine. Okay. This, we have discussed them completely, believe me. Okay. And this was meant to be a repetition and a practice for you, but it's taking so much time from us to discuss. I don't want to not discuss the spine. Okay. All these studies you should know. Sorry, we have to cancel these. And now we're going to see very soon the spine. Come on, baby, where are you? Anyway, you have this, you can review it, and it discusses everything, flaps, etc. Of how to put the Papineau is something very important you should know. He described an open bone grafting technique for the treatment of chronic osteomyelitis. This procedure is based on the following principles: granulation tissue markedly resists infection, autogenous cancellous bone grafts are rapidly revascularized and are resistant to infection. The infected area is completely excised. Adequate drainage is provided. Adequate immobilization is provided. The antibiotics are used for prolonged periods when you're using this technique. And they reported an 89% success rate with the Papineau technique. So once the area, the bed is cleaned, then you can apply multiple pinpoint grafts. They will take, and the response would be good. And this is indicated in chronic osteomyelitis. So it's divided into 3 phases: excision of the infected tissue without or with stabilization using an external fixator or intramedullary rod, cancellous autografting, and then finally skin closure. And this shows you of how the bone graft is applied over the defect. Okay? So you have to know the Papineau technique. This is a demand that we always ask. I have to come to the spine. Here we are, come. Yeah. What about vertebral osteomyelitis and discitis? In the neck, let us take the cervical spine. The platysma muscle lies beneath the skin and subcutaneous tissues, extending from the mandible to the superficial fascia over the chest. Below the platysma is the superficial layer of the deep cervical fascia, which contains the superficial nerves of the neck. The prognosis for spine infections has improved dramatically in recent years as a result of advances in the diagnosis of pharmacotherapy and surgical treatment. In view of changing patterns of pathogenic organisms and the emergence of resistant strains, however, it is essential for the spine surgeon and infectious disease specialist to work closely in the management of spine infections. A favorable outcome requires a high level of diagnostic acuity to avoid delays in diagnosis, use of culture-directed antibiotic agents, and appropriate surgical intervention when indicated. This focuses on the essentials of the adult pyogenic vertebral osteomyelitis discitis for a comprehensive review of spinal infections, including pediatric and post-operative spinal infections. Many excellent sources are available. Bit about the epidemiology. Pyogenic vertebral osteomyelitis represents 2 to 7% of all instances of pyogenic osteomyelitis. The disease may occur at any age. It more frequently affects the approximately 2/3 of patients with pyogenic vertebral osteomyelitis are male and 1/2 are older than 50 years. Vertebral osteomyelitis can occur in all parts of the spine, but is more common in the lumbar region. Regional involvement of the vertebral osteomyelitis discitis is shown in this slide, where the lumbar region is the most common, followed by the cervical, thoracolumbar, and finally lumbosacral spine. The hematogenous vertebral osteomyelitis can result from any condition that causes bacteremia, urinary tract infections, and genitourinary procedures have been identified as the most frequent sources of bacteremia. In approximately 37% of patients, the source of infection may not be identifiable. The probable sources of infection in the vertebral osteomyelitis are genitourinary 29%, soft tissue 13%, respiratory 11%, intravenous drugs like Pseudomonas infections, found drug abuse 1.5%, and unknown 37%. Direct inoculation of bacteria into the spine can result from penetrating wounds, spine surgery, chemonucleolysis, or discography. Immunocompromised patients are particularly susceptible to spine infections. There is also a high incidence of vertebral osteomyelitis in diabetics. Staph aureus is the most frequently isolated microorganism in patients with vertebral osteomyelitis. In one report from the post-antibiotic era, Staph aureus was the causative organism in 55% of patients. The most frequently isolated gram-negative organisms are E. coli, Pseudomonas species, and Proteus species, and these are often found in association with genitourinary tract infection. Heroin users are known to have Pseudomonas aeruginosa and is a common cause of spinal infection. Salmonella osteomyelitis is rare and generally occurs in patients who have acute intestinal tract infection. However, the interval between gastroenteritis and the onset of osteomyelitis may be quite long, and in some patients, no previous infection can be identified. Infections caused by anaerobic bacteria are typically associated with foreign bodies, open fractures, infected wounds, diabetes, or human bites. Indolent infections caused by low virulent organisms such as diphtheroids and coagulase negative staph leucococci often result in delayed diagnosis. Although the nucleus pulposus is an avascular structure, experimental evidence has demonstrated that it is metabolically active. Nutrients are received diffusion across the vertebral end plates and from blood vessels at the periphery of the annulus fibrosus. Previous studies suggest that nucleus pulposus is vascularized in fetuses and newborns. However, a more recent study demonstrated the nucleus pulposus is always avascular. After birth, the cartilaginous end plates become progressively thinner, but vessels within the cartilage canals may persist in individuals up to the age of 30 years before the vessels become obliterated. In children, the cartilage canals allow microorganisms nearly direct access to the intervertebral disc, which may explain the clinical differences between spine infections in children and adults. The arteriolar theory, the two major theories for hematogenous dissemination of infection are the arteriolar theory and the venous theory. In the arteriolar theory, Wiley and Troetta demonstrated a rich arterial anastomosis within the vertebral body with end arterioles in the metaphyseal region. The spinal arteries enter the spinal canal through the intervertebral foramen at the level of the disc and send out ascending as well as descending branches that supply the vertebral bodies above and below. The authors demonstrated that bacteria could easily spread hematogenously to the low flow vascular arcades in the metaphyseal region of adjacent vertebrae. The intervertebral discs may then be destroyed by bacterial enzymes in a process analogous to the destruction of cartilage in septic arthritis. Infection also may start in the metaphyseal region of one vertebra and subsequently spread across the avascular disc by lysosomal destruction of the nucleus pulposus or through vessels anastomosing on the periphery of the annulus fibrosus. In the venous theory, the Batson venous plexus has been suggested to be the root of infection. Using both live animal and cadaveric models, Batson demonstrated that bacterial seeding may occur through the valvulus vertebral venous complex in a retrograde fashion in response to changing intra-abdominal pressure. However, while Antroetta suggested that the Batson plexus or complex is an unlikely source of hematogenous seeding because they subsequently found that considerable force is required to fill the small metaphyseal venules in a retrograde fashion compared with the ease of injection of metaphyseal arterioles. Adult discitis. It has been suggested that adult discitis and vertebral osteomyelitis are separate entities. It is conceivable that hematogenous seeding of adult intervertebral discs could occur directly through persistent vascular channels or degenerative defects in the end plate, or through blood vessels at the periphery of the annulus fibrosus, and perhaps gaining access through tears in the annulus fibrosus. If adult discitis occurs at all, hematogenous involvement of the metaphysis is by far the most common mechanism, whether the infection starts in the metaphysis and spreads across the disc or vice versa. The clinical appearance and management of infection are the same. Spine infections have variable manifestations that are determined by virulence of the organism and the resistance of the host. The presentation may be acute, subacute, or chronic. Fever is present in only 52% of patients overall. Pain in the back or neck is more common and occurs in approximately 90% of patients. Patients with acute infections will have fever, local spine pain, severe muscle spasm, and limited spine motion. Hamstring tightness, loss of lumbar lordosis, a positive straight leg raising test, reluctance to bear weight, and hip flexion contracture caused by psoas irritation may be observed in patients with lumbar involvement. In patients with cervical osteomyelitis, torticollis, and fever may be the only presenting sign. Patients with subacute or chronic infections often have a vague medical history and a more insidious presentation. Pain may be the only symptom, especially in patients with an occult infection by a low virulence organism. In addition, approximately 15% of patients report atypical symptoms such as hip pain, radicular symptoms, meningeal irritation, chest pain, and abdominal pain. Neurologic deficit is seen in approximately 17% of patients and may result from direct compression of the spinal cord or nerve roots by epidural pus, granulation tissue, or bone and disc from the development of spinal deformity and instability. Additional causes of spinal cord or nerve root injury include ischemia caused by septic thrombosis or damage by inflammatory infiltration of the dura. This patient with a disc space infection at T7, T8 level and vertebral osteomyelitis, acquired progressive paraplegia as a result of overwhelming sepsis associated with antibiotic-induced neutropenia. You can see it over here. Early myelogram shows a T7-T8 disc space infection and end plate sclerosis. You can see it over here. AP radiograph showing a paraspinal abscess at the area of the arrows, centered over T7-T8. This is an illustration of the pathology which shows the end plate changes and paraspinal abscess at T7 and T8. This is the usual presentation. You see, this is the paraspinal abscess. You see destruction of the disc space. So this is 2 months later, the infection has spread to the T9, T10 into space. This shows you the gross pathology specimen showing this destruction of core at T7, T8, T8, 9, and T9, T10 levels. Factors that predispose patients to paralysis include diabetes, rheumatoid arthritis, systemic therapy, increased age, and more cephalic level of infection. Laboratory studies show an increased leukocyte count in only 42% of patients with pyogenic vertebral osteomyelitis. Patients with chronic disease usually have a normal leukocyte count. The erythrocyte sedimentation rate is more sensitive test. In one study, the ESR was increased in 92% of patients. Assessment of C-reactive protein level is quite helpful in the diagnosis of postoperative discitis. Unfortunately, both ESR and C-reactive protein level have low specificity because any infectious or inflammatory process will increase these values. The C-reactive protein level will begin to increase within 4 to 6 hours after the onset of infection or other inflammatory process. It doubles every 8 hours and peaks at 36 to 50 hours after the onset of infection. The C-reactive protein level has a half-life of 24 to 48 hours. In contrast, the ESR does not begin to increase until several days after the onset of infection and peaks at 7 to 8 days. In addition, the ESR remains increased for more than 3 weeks after the onset of the infection. The C-reactive protein level, in contrast, decreases more rapidly and returns to normal. So the same principle applies in the spine as it applies in other regions. The C-reactive protein is the first to return to normal level. ESR at a later date. Keep this in mind. Postoperatively, the C-reactive protein level normalizes in 5 to 14 days, whereas the ESR takes 21 to 40 days to return to baseline. Therefore, an abnormal increase in C-reactive concentration 1 to 2 weeks after spinal surgery may represent the onset of postoperative infection. Blood cultures are positive in 24 to 49%. of patients with pyogenic spine infections. Urine cultures are less reliable because patients may have a concurrent urinary tract infection with a different organism. Imaging studies are crucial to localize the infection, to assess the extent of involvement, and determine response to treatment. The plain radiographic findings are characteristic, but do not appear for at least 2 to 4 weeks. This space narrowing is the earliest and most constant radiographic result and is found in 74% of patients at presentation. Approximately 3 to 6 weeks after the onset of infection, lytic destructive changes can be noted and usually begin in the anterior aspect of the vertebral body, adjacent to the disc and diffusely in the end plate. After initiation of treatment, radiographic findings generally lag behind the clinical response by 1 to 2 months. With healing, spontaneous fusion occurs in slightly more than half of the patients, but may take up to 5 years. In addition, a fibrous ankylosis may occur in the absence of solid bony fusion. Radionuclide studies allow early detection and localization of infection and may show evidence of infection before plain radiographic changes are noted. So, these are the imaging modalities and the accuracy in this imaging. You can see that MRI has 96 and 93%, 94%, and it's very close to the PET scans, 100%, 87, and 96%. Gallium scans show evidence of infection sooner than technetium scans, and combining technetium and gallium scans results in 94% accuracy. No evidence of infection on technetium and gallium scans may be associated with infection by low virulence organisms. Indium-111 labeled leukocyte imaging is not sensitive in identifying spine infections. CT findings in patients with vertebral osteomyelitis consist of cystic changes in the bone, soft tissue masses, gas in the soft tissues or within the bone, and discs and later lytic destruction of the vertebral body. This is a CT scan, a lateral radiograph, shows an end plate destruction at L2-3. Now, gallium bone scan demonstrates an increased radionuclide uptake in the mid-lumbar area. This is a CT scan. CT scan reveals significant destruction of L3 vertebral body. This is an MRI, a sagittal T1 weighted MRI scan showing this decreased signal intensity in the L2 and L3 vertebrae. This is a T2 weighted, the increased signal intensity is shown at the L2-3. Gadolinium enhanced T1 weighted MRI scan, which shows the increase. So, in other words, we are using the same radio imaging we use in all cases of septic and osteomyelitis. The spine, you have to be more alert. and plain X-rays are late in showing any change. You can have a vertebral osteomyelitis and you can have a discitis. But these are two different entities. But one can occur secondary to the other. This is a Craig needle at L2-3 level culture, positive for Staph aureus. Fluoroscopic guidance can be performed at or below L1, whereas CT guidance is recommended above this level. CT is valuable in differentiating pyogenic spondylitis from a tuberculosis or fungal infection in pyogenic spondylitis. The soft tissue components tend to be less prominent than in tuberculosis or fungal infections. MRI is currently the imaging modality of choice for evaluation of spine infections. Early diagnosis of infection and recognition of paravertebral or intraspinal abscesses are possible with MRI without the risks associated with myelography. MRI also provides more anatomic information than bone scanning and can differentiate degenerative and neoplastic disease from vertebral osteomyelitis. MRI is more sensitive to motion degradation. However, there may be problems with patient positioning and claustrophobia. Additionally, some patients, for example, those with cardiac pacemakers, are not able to undergo MRI. In one study, 22 patients with vertebral osteomyelitis, gallium-67 scintigraphy with single photon emission was shown to be equally sensitive to MRI and more specific, 92% versus 71% in detecting the diagnosis. Vertebral osteomyelitis produces characteristic changes on MRI. On T1 weighted MRI scans, there is a confident decrease in signal intensity of the vertebral bodies and adjacent disc, making the margin between vertebral body and disc indistinct. On T2 weighted MRI scans, the signal intensity is higher than normal in the involved vertebral bodies, and the intranuclear cleft, normally seen within the adult disc, is generally absent. The administration of gadolinium generally enhances the disc and the involved portions of the vertebral bodies. In a study by Jan and associates, the typical changes in the vertebral body and end plates on T1 weighted MRI scans and the changes in the disc space on T2 weighted MRI scans were found in 95% of patients. Only 56% of patients had typical vertebral body changes on T2 weighted MRI scans. If the other typical findings are present, isointense or decreased signal intensity in vertebral body on T2 weighted MRI scans is still consistent with infection. So enough for imaging. I just want to mention something. We spoke about all these. About the biopsy, I care. Open biopsy should be considered if a second closed biopsy, I want to see false negative. Let me see. Okay, an absolute diagnosis of vertebral osteomyelitis requires bacteriologic or microscopic examination of the tissue, except when a positive blood culture is found in a patient with signs and symptoms of spondylitis. CT-guided biopsies of the spine have been shown to be safe and can be done at all levels of the spine. Closed needle biopsy will yield a definite diagnosis in 68 to 86% of patients. False negative biopsy results are common in patients receiving antibiotic therapy at the time of the biopsy. If the clinical situation allows, it is reasonable to repeat the biopsy after antibiotic therapy has been discontinued. Open biopsy should be considered if a second closed biopsy also is non-diagnostic. One study in the literature found that 30% of needle biopsies, specimens, and aspirates were sterile, compared with only 14% of surgical specimens. This patient had a tracheotomy and history of esophageal carcinoma and radiation-induced esophageal strictures. I don't want, these are a case presentation. I don't want to present. Biopsies should be taken and followed by culture, which, if possible, and antibiotic treatment. So let us come to a final conclusion. In the spine, many of these patients present you with back pain. Some present you inability to walk, with fever, and if you do blood studies on them, you see that they have an elevated leukocyte count and an elevated sedimentation rate and C-reactive protein. The whole plan is to identify the organism. Once you have these, and you want to do a biopsy, you can do a core biopsy or needle biopsy or a true cut biopsy through the posterior approach into the vertebral body. Now, together with this, you try and obtain a specimen and you culture it. You should try and obtain more than one specimen at different locations, but this is difficult in the spine. It's much easier in the extremity. Once you identify the organism, which is so in around 40 to 50% of the cases, then you start the antibiotic therapy. We use PCR a lot in the diagnosis. We have a high incidence of tuberculosis, fungus infections. You have to pay attention to other things when you're doing the biopsy for anaerobic organisms. So, in all these patients, once you've made the diagnosis, you start with conservative treatment with the necessary antibiotics and the rest. Then, if the patient does not respond, then you have to end up doing surgery, doing an anterior and posterior immobilization of the spine. You can use metals, namely titanium, fixation, even though you have an infection. And this is so for spine surgery. And I tell you, thank you very much for attending this long and boring lecture. Okay? But I'll tell you, you have to be aware that the spine is in many ways similar to other infections, but more difficult to identify the organism. And we cannot wait too long. If you have an epidural abscess and it's pressing on the cord, they can end up paralyzed, these patients. So you have to pay attention to this. You have to go anteriorly, clean up, put a stratigraph, and then go posteriorly. And all these procedures you have to do, cultures, and do a full workup on your patient. If you have an abscess in the thoracic spine, you can do a costotransversectomy to evacuate the pulse and use some sort of fixation to stabilize the spine. You have to use, of course, bone grafting, which is autograft. So this is the topic of infection. Thank you very much.
Well, thank you very much.
Yeah, Khalid, I didn't want to go so much into spine, but they have to have an idea about the spine. They have to know that it presents the same blood studies are nearly the same that we ask for any other bone in the infection. They have to know. They have to know about core biopsies, needle biopsies, MRIs, what they and they have to know that the vertebral body infection is different than a discitis. ما لازم يحكوا اثنين كواحد. يلا ليك خالد, I will be calling you لأن I'm going to Libya to examine in the Libyan board on the east. أنا رح بحكيك هلا بعد شوي, بحكيك على التليفون وبفسر لك كل شيء. أوكي؟
أوكي. والمحاضرة اللي بدنا نلقيها يعني البرنامج جاهز صح؟
عندنا مرتين رايحين. أنت رايح مرة على ليبيا, أنا رايح مرتين. طلبوا مني روح. مش رايح أنت؟
رايح على الامتحان. رايح.
إيه بس أنا رايح على كمان على الامتحان الليبي. طلبوني اكزامن بالليبيان بورد كمان
قبل العربي.
ايه بس المشكله رايح ب7 برجع ب11, بعدين بدي ارجع اروح بعد جمعتين للعربي.
ايوه
هيدي متعبه. يلا I will speak with you لان كيف بدنا ننظم اللكشرز.
والله يعينك.
يلا باي.
اوكي ثانك يو very much.